We're very honored to have Dr. Trisha Pasricha talk to us. She is a neurogastroenterologist and clinical research director of the Beth Israel Deaconess Medical Center Institute for Gut-Brain Research. Her clinical expertise focuses on patients with overlapping neurological and gastrointestinal disorders, and her lab studies gastrointestinal complications and possible gut-first origins of Parkinson's disease. Outside of her research, Dr. Pasricha is also the Ask the Doctor columnist for the Washington Post, where she answers a wide variety of health questions submitted by readers each week. And we're happy to have her talk to us today about GI symptoms in Parkinson's disease, what patients need to know.
Hi, everyone. It's a pleasure to be here. I apologize in advance. I made this PowerPoint on a Mac, and it seems like I would never use Courier New, so just bear with me here. My disclosures are just that I have research funding from the AGA and the Parkinson's Foundation. So what I'm going to do is talk about a couple of things. So first, I'm going to talk about the spectrum of GI issues in Parkinson's disease, which I bet a lot of us in the room are really familiar with already. We'll talk about why GI symptoms happen in Parkinson's disease, ways we can treat them, what kinds of symptoms that you might have, which should prompt you to maybe talk to a gastroenterologist, and then talk about some of the gaps in our knowledge and some of the research programs that we have going on. So Parkinson's disease, as everyone here knows, it's more than just your motor symptoms, right? So there's sleep disorders, there's issues with smell that can happen sometimes, but GI issues are what I focus on, and these are the symptoms that can often happen 10, even 20 years before motor symptoms start. So GI symptoms are very, very common in Parkinson's disease. And this is a graph that's showing some of the spectrum of the non-motor symptoms that we often see, right? Sleep disturbances, any psychiatric disorders, issues with urinary continence. Gastrointestinal complications are among the highest, right? 80% of Parkinson's patients tend to have it. And the issue that I often hear with my patients in my clinic is that it's the GI symptoms that are really associated with a lower quality of life. And some studies have done, and maybe this is something that resonates with you guys, is that people have often said, if I could trade away one thing, I would trade away my constipation, not even the motor symptoms or the tremors, the rigidity. And that's how bad it can be sometimes. So what are those GI symptoms? There's drooling, there's trouble swallowing, nausea and vomiting, bloating is really a miserable symptom, constipation, pelvic floor dysfunction. And they affect about 70 to 80% of Parkinson's patients. And we're going to talk about each of these symptoms individually. But for just a moment, I want to talk about, well, why do we think that there's such profound GI involvement in Parkinson's disease? So my group and several others have been looking at sort of epidemiological data, and we found that certain GI symptoms precede a Parkinson's diagnosis by years in some cases. But if you look at constipation, the spread, it can be up to 20 years that some of these symptoms diagnosed. And there's certainly a lot of patients who say, you know, I was regular most of my life, and sometimes in my 30s and 40s, I started to become constipated, or I started to suddenly find that I had trouble swallowing. And that persisted for years before any of the tremor or even maybe difficulty with smell or any of these other symptoms came on. There are some emergencies that can happen from the GI standpoint in Parkinson's. So a food impaction is one that we see from time to time, and that's when your trouble swallowing becomes so bad that it gets actually stuck in your throat, and that's a reason certainly to come to the emergency room. Sometimes there's aspiration of food contents that could cause pneumonia, and a colonic volvulus that comes and returns in about 57% of Parkinson's patients, and that's when there's a twist somewhere in the colon, and that can become a surgical emergency. And then sometimes our constipation can just become so bad that the stool is sitting there in the colon and in the rectum, and it causes inflammation, and that's called stercoral colitis. So that's sort of the spectrum of what we see in my clinic. But let's talk a little bit about the why. So for everyone in the room, let's talk about the little brain of the gut, right? So you probably learned that your body has one brain, right? But you actually have two. Your little brain is what we call the enteric nervous system, and that's what I study. That's the nervous system, a second nervous system that's in the gut. It's actually the OG. The enteric nervous system was there before the central nervous system really developed. If you go back to some of our earlier organisms like jellyfish, they don't have brains, but they have a very nicely developed enteric nervous system. And it has over 100 million neurons. So it's a lot more than what are contained in your spinal cord. It doesn't control things like philosophy or poetry. We leave that to the big brain, but it's really important for the finer things in life, which is swallowing and digestion and moving food along your GI tract. And there's a huge connection between the big brain and the little brain. And that's happening all the time, right? So if you know this from, if you ever get butterflies before you go on a date, why is that? That's because there's some connection. Your brain is telling you, I'm excited or I'm nervous about something, and your stomach is reacting to that. But what we've learned over the last 50 or so years is that that communication is not just one way, it's two-way. And a lot of the neurotransmitters, dopamine being one of them, are predominantly produced in the gut and by the enteric nervous system, and that can have a profound impact on your brain. So what is this gut-brain axis of Parkinson's disease specifically? So the hypothesis about how, at least in a subset of patients, maybe not all, but in a subset, that Parkinson's might develop in the gut, that came out about in the early 2000s. But if you go back to some of the earlier works of James Parkinson himself from the 1860s, he was writing about the profound constipation he was observing in his own patients. He just didn't really understand why. But it wasn't until about the last 20, 25 years that scientists started to figure out, well, there is this group of patients that have these GI symptoms much earlier. And we wonder if actually that's where that primary pathology is happening. We've talked a lot, I know you've heard a lot about alpha-synuclein, you're very familiar with that misfolded protein. If you look at the gut of patients who have Parkinson's disease, often you see that misfolded protein in the enteric nervous system, even in patients who have not yet developed Parkinson's disease, but who are at high risk. Maybe they have a family history, maybe they have some other symptoms like REM sleep disorders or things like this. And there's some event we think that happens in this subset of patients, hypothetically, that would trigger that misfolding. Maybe it's related to the microbiome. Maybe it's some viral insult. Maybe it's something to do with genetics and the diet. There's been a lot of discussion in my realm of the world about what kinds of foods we eat, or is it related to ultra-processed foods, microplastics? There's a lot of hypotheses, but probably there's no one unifying theory. It's sort of a multiple hit sort of thing that happens. But then it happens, and then that protein starts to misfold. And we think that it propagates through the vagus nerve. The vagus nerve is that big highway that connects the big brain and the little brain, and it's talking all the time. And eventually it can get to the brain. There's probably other pathways by which Parkinson's happens that have nothing to do with the gut. We think probably there can be a pathway that involves the olfactory system, which is through your nose and your sense of smell. And maybe there's also a group where it just starts in the brain. But more and more data is showing that actually probably in some subset it does start in the gut for people. One of the famous studies that they did in our world of neuro-GI is back in the 1980s and early 90s, when somebody had really bad heartburn, we gave them a surgical procedure called a vagotomy. So we just cut part of that vagus nerve. That sounds really extreme. It was really extreme, but we did it because we didn't have proton pump inhibitors. And now things like omeprazole, pantoprazole treat heartburn really well. But what that allowed us to do is do these large epidemiological studies where we looked at, well, what happened to those people which was a lot of people who got vagotomies, and it turned out they were significantly less likely to develop Parkinson's later in life. And we think that that has to do with cutting off the transmission from the gut to the brain. And subsequently, scientists were able to show in recreating Parkinson's in a mouse model that if you injected this kind of protein that's likely to misfold into the gut, and you cut the vagus nerve in animals, these mice did not develop Parkinson's. But if you left the vagus nerve intact, they all develop Parkinson's eventually. So this is part of the hypothesis. Something that my lab has been studying is the role of mucosal damage in GI. So this is a paper that we published earlier this year. The hypothesis is that, well, what are all these triggers in the environment and in our foods? And something that my patients in my clinic started to tell me was, 20 years ago, I had this stomach pain I couldn't quite understand. It was like a couple weeks. I didn't think much about it. Some patients were like, I went to the ER and I had a peptic ulcer. It was obvious. Sometimes people said, I just was taking a bunch of ibuprofen, a bunch of Aleve, NSAIDs because I sprained my ankle one time. And yeah, I felt a little sick, but I never thought about it again. But I heard stories like this over and over. And we ultimately did a study where we found that people who did have damage to the lining of their stomach about 15 years in advance went on to develop Parkinson's disease about 76% more likely than people who did not have that kind of damage. So whether this is the thing that triggers the kind of pathological alpha-synuclein misfolding, we don't quite know. That's what my lab is studying now, or whether this did something else that changed the milieu in the enteric nervous system that ultimately puts someone at higher risk. We're trying to tease those things apart. But all of these studies together are telling us that that relationship between the gut and Parkinson's disease is a lot closer than people appreciated in the past. So let's talk about the things that matters most, which is the symptoms. So drooling is a pretty important part of Parkinson's, your daily life. It happens, depending on the study, there's a wide range, but it can happen to a lot of people. It can lead to trouble with speaking in public. It can lead to kind of social embarrassment. And often trouble swallowing goes hand in hand with drooling. There are a lot of medications that can help this, and that's something that it's a little bit outside of the GI realm. But I'll talk a little bit about difficulty swallowing. So difficulty swallowing, the fancy medical term for that is dysphagia. It's basically the sensation that you're choking while you're trying to swallow, or food is getting stuck somewhere. 80% of Parkinson's patients get this over the course of their lifetime, and it's actually more common in men. It's not really related to how long you've had Parkinson's or even how bad your motor symptoms are. It's pretty pervasive, but it can have a really big impact on your ability to take medications, and that's often how people end up in my clinic is swallowing just gets so bad that they actually can't take their Parkinson's medication, and it kind of becomes this vicious cycle. Now, sometimes people never make it to me because there's two big mechanisms about swallowing. One is the muscles of your mouth and the first part of your throat, and that's mostly under voluntary control, or there's a reflex that takes over, which you don't have control over. All of the swallowing mechanism that happens after about right here, where you hit the esophagus, you and I don't have control over. Your body takes over, and that's the esophageal motility part. And sometimes it can be really hard as you, as a person, you're taking this sip, you feel like something's getting stuck right here. Well, is that a problem with the muscles in your mouth? Is it a problem with the esophagus? You often don't know. And I think sometimes you might go to speech language pathologists who are the best, and they're very, very helpful. And they'll give you a lot of good tips and tricks. And yet we're still getting stuck with why is food not moving down further? And that's when I start to think, well, maybe the problem is actually in our esophagus and it's not so much up in the mouth. It can be both. So the first step, if you have trouble swallowing, is to talk to our speech language pathology colleagues. They usually do a test called video swallow study, and some of you may have had this before. And they talk about kind of adjusting your body position while eating. The main thing that a lot of people worry about is this risk of aspiration, meaning like kind of having food go down the wrong pipe and into the lungs. And they kind of can offer things like muscle strengthening exercises. We can talk about thickening liquids. One thing that I like to share with patients that really addresses some of the problems with swallowing that start in the mouth that I think people are less familiar with are these two tricks to help swallow your pills, right? And I think sometimes people think like when we take a pill, like in the movies, everyone takes a pill and then they like chug their water like this. And like, that's the weirdest way to take a pill. It's not how you're like, you're closing off your glottis when you do that, right? If you want to, you can look up this article I wrote in the post that explains it, but this is a diagram of the two things. And really there's two different ways that help you swallow pills most easily, depending on if it's a tablet or a capsule. So first, you have to know, is it a tablet or a capsule? A capsule you can open, you can see a little seal in the middle. It's something you can open. A tablet is just a flat disc. If it's a tablet, you actually, one easy way to swallow them is to take a bottle of water and make a full seal around the bottle. And then it kind of like you're suctioning against it. And then when you kind of chug the water into your mouth, it immerses that tablet in the water. So it just passes through so that the tablet is not sitting heavily on your tongue, which is what we usually do. We put it on our tongue and then we take a sip and it's like, oh, and it's like chugging along the back of your throat. When you do this method and you make a full seal around the bottle of water, it immerses it. And so it just goes down with the rest of the liquid and it's a lot easier. And similarly, if it's a capsule, which naturally floats a little easier, when you take a sip, you want to tuck your chin in. That feels so paradoxical. It feels so against what you want to do, which is what you want to do in the movies and like have a nice swig that way. Don't do that. Try this at home. Tuck your chin in and see how much easier your capsules go down. So sometimes I find when I just tell my patients to do this, they get like 50% better and we don't have to do anything profound or invasive. So keep that in mind. But sometimes people don't. Sometimes there's something else going on in the esophagus, like I mentioned. When that happens, there's not an easy answer I can give you in the clinic. What I'd like to do in that scenario is do a test called an esophageal manometry test. And that's what the output of that test looks like. And basically, it's a simple test that we do. It's an outpatient procedure. It's not nothing that requires sedation, takes about 15 minutes, but it's something that's really just done by the gastroenterologist in your life. And it looks at the pressure waves in your esophagus and sees what's contracting. And very importantly, it looks at what happens by the time whatever it is that you're trying to swallow, a bolus of water or food, makes it to that sphincter that connects the esophagus to your stomach. And when that happens, sometimes we can treat, if there's an issue with that sphincter, we have lots of different ways that we can treat to kind of loosen that sphincter up, which is commonly a problem in Parkinson's disease. Let's talk about nausea and vomiting. So nausea and vomiting is very, very common. About 40 to 70% of patients have it. There's a lot of different etiologies. So one is this issue of delayed gastric emptying. Delayed gastric emptying is also called gastroparesis. And basically that means that your stomach is not emptying as rapidly, quickly, normally as it should. So you feel full so easily. You feel nauseated when you've just eaten a little bit, or you kind of have a lot of bloating and you have a low appetite. And that's just largely because the food's not moving along as it should. It's not emptying into the small bowel. It's not giving you space to keep on eating. And there's this paradoxical issue that happens in Parkinson's in particular. Some of you may realize the medication itself, levodopa or any of these dopamine replacement therapies, they actually delay gastric emptying even more. So sometimes you guys might have experienced, you take your medication and then you feel nauseated afterwards. But actually you were nauseated in the first place. You're trying to treat the nausea in the first place, and it becomes this cycle. It's complicated about why this happens. We think that there's a primary problem with dopamine regulation in the gut that may or may not be related to the dopamine problem in the brain. And dopamine itself delays gastric emptying. So when you're giving something like dopamine, it can cause problems. All of this said, the good news is we have medications that can treat it, that can block the receptors in the gut, so that when you take that medication, which you're trying to get to reach your brain, you really don't want it to slow things down in your gut. You want it to be absorbed. You want it to hit your brain. We have medications that can block those receptors in the gut. And so that you really just try to maximize the effect of it that you want and not get the side effects you don't want. So, but there's lots of different ways we can do that. But if this is something you're struggling with, it's worth talking to a gastroenterologist about how we can help and what things we can offer. We have things for medications. Sometimes there's a bacteria that overgrows. It's called H. pylori. It lives in a lot of our stomachs. It's more common in Parkinson's disease patients. I often test for it. Sometimes simply eradicating that bacteria, it's 2 weeks of antibiotics. That takes care of the problem with absorption. So there's a lot of different things we can think about if this sounds like you. And then one test that we do to look for delayed gastric emptying, that's usually the first thing. It's called a gastric emptying scintigraphy study. It's a nuclear medicine study, very cool. You eat these radio-labeled eggs. It takes 4 hours. You bring a good book. You watch a nice rom-com on your phone, and you take the eggs at hour 0, and then we take another picture at 1 hour, 2 hour, and 4 hours. And if by 4 hours you haven't emptied 90% of that yummy egg, radio-labeled egg sandwich, you probably have delayed gastric emptying, and then we can treat that accordingly. So gastroparesis does have several consequences. So, I mentioned you guys, a lot of people take levodopa therapy. The more that the stomach breaks down levodopa, because the stomach contains an enzyme that breaks it down, the less your body is absorbing it. So the longer the levodopa sits in your stomach, the more delayed your emptying is, the more that medication is getting broken down before it can be absorbed in the small intestine. So less of it is reaching your motor symptoms. So sometimes just by kind of improving your gastric emptying, people find that their motor symptoms can improve as well, because the medication is able to work better because you're absorbing more of it. Some practical tips you can try right now that have nothing to do with my testing, nothing to do with any medications. If you're experiencing nausea, vomiting, we wonder if you might have gastroparesis, are things to avoid delaying your gastric emptying even further. So high fat meals, like anything you might get that's been deep fried, for example, or a lot of dairy, those things slow down gastric emptying. Those are the kinds of meals that I might avoid if you're taking your levodopa around the same time. Indigestible fiber. So every gastroenterologist is going to tell you to eat more fiber. I love fiber. In this scenario, Don't eat that much fiber, because fiber tends to delay gastric emptying as well. So if you're eating like a lovely kale salad with your levodopa, you're slowing down how quickly your body can empty and push that levodopa medication into the small intestine. So you didn't hear it from me, a gastroenterologist, not to eat fiber, but just when you're having your medication, try not to do anything that might put a little bit of stress on your stomach. If that sounds like you, if you have a lot of nausea, if you have a lot of these on-off phenomena. And certainly liquid-based meal supplementation, things like Ensures or Boost, those are empty very quickly. They're high in protein, so they're very good for you if you need to have something with your levodopa therapy. Let's talk about the one that we all want to talk about, constipation. So what is constipation? First of all, defining constipation can be really hard. Everybody thinks they're constipated in this room, I bet, and everyone's definition of what that is a little bit different. So officially, from a gastroenterology standpoint, you have to have 2 or more of one of these things. So one, straining, hard stools. I often ask my patients, do you have this sense that you didn't get everything out after you go? Are you using manual maneuvers to have a bowel movement? That's common, more common than you think. And sometimes we just say, okay, let's put a number on it. Are you having less than 3 spontaneous bowel movements per week? But as you can see, some people are going to define constipation by saying, oh, I have hard stools. Some people might not have hard stools. They might have loose stools, but they're straining a lot, or they don't feel like they get everything evacuated, even though the stool form might be normal. You might still be constipated in that scenario. There's different kinds of constipation that I study. So there's normal transit constipation. That means the kind of gut motility is okay. Things are moving along just fine. But for some reason, and we'll talk about why, we're not getting our stool out. There's slow transit constipation, which means the primary issue is the motility. The gut's not squeezing, it's not moving. That's the problem that we need to address. And then there's pelvic floor dyssynergia. Pelvic floor dyssynergia is so underappreciated and underdiagnosed, but it hits about 40 to 60% of Parkinson's patients. So that's a huge number of people. And well, what is pelvic floor dyssynergia? It might be a new term for some of you, but I liken having a bowel movement to trying to get toothpaste out of a toothpaste tube, right? So some of the medications we give you are trying to augment the squeeze of that toothpaste tube. Those are like stimulant laxatives. And some of the medications we're trying to soften up the toothpaste so it can flow easily. And that's like Miralax or any of these osmotic laxatives that you might take. But no matter what we do, if we don't take that cap off the toothpaste tube, you're going to squeeze and squeeze and squeeze, and you're not going to get any toothpaste out. And that's what the pelvic floor is doing. Sometimes the pelvic floor, the muscles that are supposed to relax when you're having a bowel movement don't relax, and the ones that are supposed to contract just at the end to push things out are relaxing, and it's very paradoxical. So this is common. The problem is that all of the medications in the world are not going to fix pelvic floor dyssynergia. The good news is that pelvic floor dyssynergia, 80 to 90% of patients find an improvement with pelvic floor physical therapy. So it's something that can be improved. We can fix it without necessarily having to give you a medication, but we have to diagnose it. We have to recognize it. We have to appreciate it. And the first step to doing that is a test called an anorectal manometry. And an anorectal manometry, it's a test that we do in clinic, 15 minutes, no big deal, outpatient. But the kind of thing about it that might be a little bit surprising to people is that we basically inflate a small balloon in the rectum and we have you push it out. It's a really friendly staff. They do 20 of these a day. There's nothing embarrassing here. And then it's over. And basically that balloon is measuring the pressures that you're generating in the rectum, in the sphincter. And based on what those pressures look like and the effort you're giving, we can say, look, you're supposed to be relaxing that sphincter and it's just tightening up when you're trying to push. And then if that happens, we can make the diagnosis and then we can refer you to physical therapy. And the important thing that I tell patients, and this is a test for slow transit constipation, it's basically an x-ray. The important thing about anorectal manometry testing, this is a schematic of the balloon, is that you go to a physical therapist that offers something called biofeedback. Okay, so a lot of my patients will say, well, I go to a pelvic floor physical therapist. I have urinary incontinence. I'm seeing them anyway, or sometimes women after childbirth end up kind of going for a lot of reasons to a physical therapist. It's a totally different thing, what we're talking about in GI for constipation. It has to be someone who offers biofeedback. What biofeedback is this nice technique that certain physical therapists offer. So you have to call and ask, where they use your body's own measurements to kind of inform what you're doing. So like one example is they might put electrodes on your stomach, on your abdominal wall, and then you'll see like what the muscle contraction and is doing in real time, and they'll say, okay, bear down, try to bear down, and you might notice, oh my gosh, I'm like pushing all of this energy up into my face instead of pushing it downwards and relaxing the pelvic floor. And you can see that in real time, and it's actually a very useful tool. It's the thing that tends to help people do really well, and it's the thing that studies have shown help with pelvic floor dyssynergia. So just remember that word, biofeedback. But anyway, before we get there, you'd have to see a gastroenterologist to get the test, so we would talk about it. But what can we do right now to manage your constipation? So that's what you could do when we talk and we have a visit together. But here's a couple of things, and this is if you wanted to, you could look up the story I wrote in the New York Times last year. But that has people often want to say, okay, what are the natural things that I can do really quickly? So one, if you're not using a squatty potty, you're behind the times. Squatty potty is great. You don't have to actually buy a squatty potty. You can use a stool, you can use a stack of books, you can wear high heels. As long as you get your knees sort of above your waist, what you're trying to do is open up that angle that allows stool to move more closely. This 90-degree that we usually sit at is actually very unproductive, and the muscle is basically a sling, and that sling is tight and closed when we're just sitting at a 90-degree angle. So anything you can do to lift your knees up will improve. So there's about 1 in 6 people who have constipation who would have failed our anal rectometry test. 1 in 6, just by lifting their knees up above their waist, will pass, will be able to get their stool out. So it's a pretty big number for something that just costs nothing. So you probably many people will have already tried fiber. Honestly, drinking more water is like, we say that usually at the point at which you have constipation, you're seeing me, water's not the issue anymore. Dried prunes work really well. People are already doing that often. What people are doing less often is kiwis. So in the last 3 years, the GI world has done these randomized controlled trials looking at prunes versus kiwis, and it's like all the rage in GI. 2 kiwis are more effective than prunes, more effective than an osmotic laxative like Miralax in getting an effective bowel movement. The dose is 2 kiwis a day, can be green or gold. You don't have to eat the peel, although you can, lots of nutrients, but you don't have to, according to the studies. And the nice thing about kiwis is that people who eat a lot of prunes say, 1, they're gross. 2, I bloat so much with prunes. Kiwis don't cause bloating, and the trials have shown that. So if you're looking for a nice alternative, you want something natural, I tell people to try these things at home before we do anything more exciting. I know we're running low on time. I'll just say, and maybe I'll save these for later. These are some of the common questions that my own Parkinson's patients ask me, and I'm happy to talk about them. Maybe I'll hone in on this one about, will I become dependent on laxatives? I talk about this like 10 times a day. There's this idea in the literature that maybe in folklore, that if you take certain laxatives like senna, bisacodyl, you'll become dependent on them, or that you'll need them for you'll never have a normal bowel movement unless you take them. And one, that's not true. Studies of looking at the enteric nervous system have found that medications like senna actually don't do any damage, because this is such a common question. But 2, it's well, you're not having a normal bowel movement unless you take them. So shouldn't you take them? I mean, we don't tell people who have high blood pressure, well, if you keep taking blood pressure medication, you're going to become dependent on it. We better get you off eventually. I mean, we want to treat your blood pressure. And it's the exact same thing to me with constipation. So don't hold back. Take your senna every day if you need it. In fact, I often prescribe medications, Linzess, linaclotide, all these things, and people take senna in addition to that, because sometimes you just need the extra kick. So feel liberated. Don't take more than what's written on the box, but don't feel scared either. And I'm happy to take other questions. So people often ask about the microbiome in Parkinson's disease, and there have been, it's a hot area. It's been a hot area of research in GI in general. We're just a little bit ahead of the science, though, I think, in terms of what we could practically do with modulating the microbiome. So we know there have been a lot of studies that have shown that patients with Parkinson's disease have a so-called altered microbiome. There's different types of bacteria that may be present. They may be producing different kinds of different kinds of things, but we don't know if that's sort of a cause of Parkinson's. I'm not sure about that. We don't know if it's an effect of something else that they're taking because they have Parkinson's, all of which is to say there was a really big meta-analysis that was published, I think JAMA Neurology, I can't remember, but it was a big journal earlier this year that was a meta-analysis of multiple trials of fecal transplant in Parkinson's disease. The outcome was looking at improvement in motor symptoms and in GI symptoms, and it failed to show that it did anything profound. That doesn't mean I don't think modulating the microbiome might not help one day. I just don't think we have honed in on how to individualize and tailor that therapy to someone's unique problem. So it's a common question. I don't know the answer to it yet, other than to say we don't offer fecal transplant outside a research setting. Probiotics are fine to take. I have patients who take probiotics and they feel that they do a lot for them and they work. The studies have really only shown that probiotics are helpful in irritable bowel syndrome, which many patients with Parkinson's have, to a slight degree. So if it helps you, I think that's fine to take. If you're taking it and it's not doing anything for you, I don't want you to keep wasting your money because I don't think the data is overly profound yet. So I'll leave that there. Can my Parkinson's medications be the cause of my GI symptoms? Actually, this one we may have touched on a little more, but the answer is yes. The levodopa can certainly be causing your nausea, and sometimes just changing how you're eating a little bit around that. Or if you're really struggling talking to me and I look for those other things, the bacteria like H. pylori, or look for other causes that might be causing nausea, we can get to the bottom of it and help with you a little bit more.
Recent studies have shown that there's links between the bacteria in the gut and cause Parkinson's. And the question I have is, if somebody's been diagnosed with Parkinson's, does it make sense for them to take antibiotics to eradicate the bacteria in the gut?
That's a complicated question. So you're right that there is a lot of research going on right now that's trying to figure out, is there some change in the microbiome that could be part of a causal pathway in a subset of patients with Parkinson's. At the point that you have, well, so one, I'll differentiate the microbiome. When we talk about the microbiome exists all over our body. Our skin has a microbiome, our scalp has a microbiome. But usually when we're talking about the gut, we're talking about the colon's microbiome. Even though there are bacteria that live up in the small intestine, we're predominantly talking about the colon. And the bacteria I had mentioned earlier, H. pylori or Helicobacter pylori, that's a bacteria that actually lives in your stomach. It's like one bacteria, most bacteria cannot live in the stomach because it's so acidic. So this is actually a slightly different bacteria from the kind that we refer to when we're talking about the gut microbiome in general. Helicobacter pylori is really up in the stomach, and it's really a problem in terms of absorption of your medications. So this is to answer your question. One, if you already have Parkinson's disease, totally makes sense to still take the medication, the antibiotics to eradicate Helicobacter pylori if you have that. In general, taking antibiotics, we do think alters your gut microbiome to some extent. I think nobody should be taking unnecessary antibiotics. Like sometimes we ask our doctors for it because we're like, well, just help me out, and you just take it, and there's not like a strong reason for it. That shouldn't happen. But if you have a good reason to take it, you should take it. Our gut microbiome is most plastic in our early developmental years, like between the ages of like newborn to like 5 years old. So it's a lot harder to mess with the microbiome as we go on. With one-time interventions. Over time, changing your diet over time certainly can. But the short answer is you should take antibiotics if your doctor really thinks you need them. You shouldn't take them if there's not a strong reason.
Thanks. And we have quite a few good questions in the chat. Maybe I'll start with the top one here. My husband has usually been constipated, but now often has diarrhea. Is that also from Parkinson's?
It's a good question. So possibly. So some of the studies have found that irritable bowel syndrome with diarrhea can be related to Parkinson's disease. But sometimes, and this is the more common scenario I see in my Parkinson's patients, what happens is your constipation actually gets so bad over time that the hard stool builds up in the gut and it builds up in the colon such that eventually only watery kind of stool can flow over that mass, and it starts to look like diarrhea because it's just water that's coming out, and it's uncomfortable. You can be incontinent when this happens, but if we treat it as diarrhea by giving you something like Imodium or loperamide to block the stool, we're actually making the whole problem a lot worse. And sometimes what we need to do is actually give you a really, really intense week of laxatives to kind of unplug everything. And then you find that the diarrhea goes away and we can just try to get you back to regularity. It's hard. It's a struggle. Sometimes in my patients, I order just a quick stomach x-ray if we're not sure what's going on, because if your stomach x-ray shows us that you have a ton of stool in your bowel and you're having diarrhea, then it's clear what we need to do.
How many times a day is normal for bowel movements?
It's a great question. How many times a day? So we've studied this. We've looked at the NHANES. Beth Israel has looked at the NHANES data set to figure that question out. And basically, wide population of Americans wrote in who considered themselves normal, who did not struggle with straining or any issues with their bowel, saying, well, how many times do I go a day? And the rule of thumb that we learned from these studies is that anywhere from 3 times per day, I know, 3 times per day to every 3 days, once every 3 days would be in the range of normal. The reason 3 times per day is normal, by the way, is because we all have this thing called the gastrocolic reflex, meaning every time we eat something, once it hits our stomach, it triggers this reflex that starts contractions of our colon. Certain foods like coffee is like a really profound trigger of the gastrocolic reflex, because you guys, you take a few sips of coffee, you have to go to the bathroom. Well, certainly it's not because the coffee has traveled all the way down. It's because of the gastrocolic reflex. So there's some people who have a stronger reflex than others. They go 3 times a day and often after meals, but going every 3rd day would still be normal. What I tell patients is that it's less about a number, but it's more about what is comfortable for you. So you might go every day, but every day you're straining, it takes you an hour, you have 6 laxatives. That's not normal. Or you might say, you know what, I go 4 times a day, but I'm happy. It doesn't interfere with my life. Like I have a great job. Nobody judges me. That's great too. And that's normal. So it's really more about you and what is sort of socially appropriate with your life and what is not causing you symptoms and discomfort and anxiety.
Let's see. The next one is coffee good for Parkinson's?
Yeah, so coffee, there's been this a lot of studies that have looked at coffee in terms of risk factors for predicting Parkinson's, and that data, and you can correct me if I'm wrong, Dr. Simon, but that data has been a little bit mixed and confusing. Once you have Parkinson's, I think it's actually a great tool to have a bowel movement. So I think there's been no study, I've looked at this, no study that shows taking coffee when you have Parkinson's makes things worse in any way. And in a lot of ways, it helps your gut symptoms. So I think in terms of like decreasing or changing risk, the data is unclear, but once you have it, I think it's great for gut health.
Another question online, you recommended increasing carbidopa to reduce nausea or other GI problems?
Yeah, that's one of the things that we think about as we start modulating the dose of the carbidopa, and that can be effective for some people. It's something that we work with, and I work a lot with people's neurologists closely to kind of make these decisions one at a time and slowly and see. And sometimes it's not, the answer is not. There's not a one size fits all for everybody. For some people, kind of modulating just that ratio with the carbidopa does do the trick. For some people, they need to kind of change their dietary habits, their eating habits a little bit. Some people, we need to just give a medication to that can block some of the dopamine receptors in the gut directly. So it's a little bit of trial and error when we're trying to figure these things out. But so the answer is that, yeah, for some people, it can be very effective.
Now, I'll just add for that, we do that especially when people are often just starting carbidopa levodopa and are very low doses, so they're not getting enough of the carbidopa yet to block the enzyme peripherally that it's aimed to block. When people are on high doses, usually they get enough carbidopa that giving more doesn't help. Maybe last question, and then we'll move on to the break here. Benefits of chia seeds or flax meal for digestion and alleviating constipation?
They're great. Chia and flax are really helpful. So also from the NHANES data set, 96% of Americans are not getting enough fiber. Like we're not meeting the dietary recommendations for fiber. So I usually tell patients, not even just Parkinson's patients, but to just take a fiber supplement. Maybe that's through chia seeds, maybe that's through flax, or maybe it's just like psyllium husk that you add to your coffee. That's that can only help your stool and your stool content. The one slight thing about chia seeds in particular is that they tend to cause a lot of bloating if you take too much of them. They can act a little bit of like an osmotic laxative as well. So that's just something to keep in mind. If you find that you're bloating, then maybe switch to a fiber supplement like cellulose that's a little bit less, that doesn't cause bloating as much.
Great, thank you very much.